Welcome, everybody. Hello. Welcome to today's webinar, Advancing Cancer Screening in California, Data, Guidelines, and Health Plan Innovations. My name is Raquel Arias. I am a staff member at the American Cancer Society, and I'm also proud to have roles with several of the organizations bringing you today's content. So in addition to the American Cancer Society, today's webinar is brought to you by the California Colorectal Cancer Coalition and the California Department of Public Health, which administers our state's cancer coalition, the California Dialogue on Cancer. We are also so grateful for the partnership from the Department of Healthcare Services, which was so valuable in bringing today's content to fruition and helping us reach such a large audience. So if folks are still joining, we've got quite a few, well over 100 registered. So we are all here today because cancer screening saves lives. With recommended cancer screenings, we have the opportunity to find problems before they become cancer and to detect cancer earlier when it is easier to treat. But of course, as we all know, not all communities are benefiting equally from cancer screening, and today's dialogue will really focus on the opportunities to increase breast, cervical, and colorectal cancer screening uptake in the communities that we serve. So who is with us today? The majority of our audience today is health plan team members. So we have representation from Medi-Cal, commercial, and Medicare plans and product lines. And our focus is on the vital role that health plans play in maximizing the uptake of breast, cervical, and colorectal cancer screening in California. We will be hearing from two health plans later in our program. But of course, this work requires the partnership of many. So we're so excited to have a wide range of partners represented today. We have healthcare delivery systems, including federally qualified health centers from throughout California, many of our California cancer centers, academic institutions, community organizations, tribal organizations, individuals from state and local health departments, and more. So thank you all for taking time out of your busy schedules to join us today for this important topic. And we look forward to today's content and discussion. Next slide, please. Just a couple of housekeeping notes. Participants are muted. This is a Zoom webinar format, so please use the Q&A feature to ask questions and make comments today. And we are recording today's session, so we'll share the recording with all of the registered participants. Next slide, please. So before we jump into the meat of our agenda, I'd like to invite Dr. Julie Pham from the Department of Healthcare Services to give some welcome comments on behalf of the department. Thank you so much, Dr. Pham, for your partnership. The floor is yours.
Thank you very much, Raquel. Good afternoon, everyone. My name is Julie Pham, a family medicine trained medical consultant with DHCS, working in the Quality and Health Equity and Transformation branch. On behalf of DHCS, I want to really extend a warm welcome and thank you all for joining on this webinar. We truly appreciate your time and your commitment to advancing the health and wellness of Californians. And we're very honored to be partnering up with CDPH, American Cancer Society, as well as the California Colorectal Cancer Coalition on this important conversation. Next slide, please. So cancer screening is one of the most important tools that we have in preventative care. And like Raquel says, it improves treatment outcomes as well as saves lives. So timely screening of breast, cervical, and colorectal cancer is crucial. It's really essential services that really help us close health equity gaps and ensure that Californians, regardless of income or background, receive the access of life-saving services. Next slide, please. And at DHCS, we continue to closely monitor breast and cervical cancer screening rates, and there is a proposed change in it, including colorectal cancer screening in our monitoring for measurement year 2026. And we're really encouraged by the progress being made across the state. It really reflects the hard work and innovation of our managed care plan partners, providers, as well as community-based partners. Next slide, please. And thank you very much once again for your partnership and your commitment. Let's continue this important work together to identify gaps and then share best practices as well as support one another in this shared mission. Thank you.
Thank you so much, Dr. Pham. All right, let's take a look at our agenda for today. We're going to be starting with a review of some cancer burden data for breast, cervical, and colorectal cancers in California from Dr. Scarlett Gomez, as well as cancer screening uptake data from Dr. Stoney Anderson. Then we'll do some questions for both. And then we have two subject matter expert presenters. We have Dr. Michael Potter for colorectal cancer screening and Dr. Sarah Temkin for breast and cervical cancer screening. And then we will be hearing from two health plan presenters about their efforts to improve cancer screening among their membership. So lots to cover. Let's get started. It is my pleasure to introduce our first speaker, Dr. Scarlett Lynn Gomez, who is a professor of epidemiology and biostatistics at UCSF and director of the Greater Bay Area Cancer Registry. A document with the bios for all of today's speakers is being dropped into the chat for your reference. Welcome, Scarlett. The floor is yours.
Great. Thank you so much. Thank you so much for having me. And I'm really pleased to be here today. I'm going to be wearing my hat as a director of one of our three regional cancer registries here in California, as well as an epidemiologist. So I'm going to be presenting to you lots of data. I know the slides will be made available. If not, you can always contact me for further information. So I'm going to fly through very quickly in my 10 minutes with a lot of data. Next, please. So I'm going to be talking about showing you some current data on patterns and trends for these three cancers across California. Next, please. And just as an outline, we're going to be looking at incidence rates and trends by different racial and ethnic groups for counties. And I'm going to show you a couple of tools that you can use on your own to look up some of these data, as well as by stage. We'll also be looking at some BRFIS data, behavioral risk factor survey data on screening rates by county in California, and then some cancer stage distributions by payer or insurance status. Next, please. So let's get started with breast cancer. Next. So these are general patterns by racial, our four largest broad racial and ethnic groups. And I'm just going to kind of hone in on one key take-home message in each slide again in the interest of time. So what we see generally is that declining trends among non-Hispanic Blacks, stable trends in white populations, but very large increases over time, especially in the recent years among Asian Americans and among Hispanics in California. Next. With regards to age, I think this graph shows the well-publicized recent trend that we've been seeing, which is if you focus on the lower part of the graph, we still see lower rates in general, but definitely steadily increasing trends in early onset breast cancer. So that is breast cancer that occurs under the age of 50, specifically in the 40 to 49 age group, we see 1.15% per year, and then even a larger increase in the 20 to 39 age group. Next, please. There are two tools actually that are available for us to extract information in California of cancer incidence and mortality rates by county. So these two tools, I put the URLs for them at the bottom of the slide. It's California Health Maps and the CCR's tool called Cal Explore. I'm just showing you here a heat map by county of breast cancer incidence rates. The average state rate is 126.6, and these are the 10 counties in California that have the highest rates of breast cancer. So you could see we continue to see the highest rate of breast cancer in Marin, followed by Santa Cruz, Sonoma, Yolo, San Mateo, and Santa Barbara. Next. These are data from the Behavioral Risk Factor Survey in 2022 looking at breast cancer screening. So specifically women aged 50 to 74 who reported having received a mammogram in the past 2 years. This is all races, ethnicities combined, and it's showing you again a similar kind of heat map by counties across California. The state average here is 76.3, and then here I'm showing you the 10 counties that have the lowest screening rate. So there is some variability. I know we're Stoney's going to talk about some trends over time, and we are seeing progress, but we still continue to see some counties with lower than desired screening rates. Next. And here we are looking at the incidence rates specifically for distant stage disease. Okay, so this is showing you that, as we know, non-Hispanic Black women have the highest rates of distant stage disease. And I think a undesirable trend that we are seeing here is that the rates of distant stage disease seem to be increasing across all of our these four major racial and ethnic groups. The fastest increases that we are seeing are among Asian American Pacific Islanders at 4% per year, and among Hispanics at 3.8% per year. Next. Here we are looking at the distribution of breast cancers by stage across different payer types, payer status. So this is a proxy for insurance status. And the takeaway here is that for publicly or uninsured women, so specifically for Medicaid, other types of public insurance, and non-insured women, we do see a higher proportion of breast cancers diagnosed at regional but also distant stage disease. Next. And then finally, we are looking at mortality trends over time across different racial and ethnic groups. And we expect that the increases that we're seeing, especially in incidence rates of distant stage disease, may caught up with the mortality trends, but generally we are seeing declining mortality rates, with the exception of the Asian American group, for whom mortality is stable over time. Next. So now we'll move on to colorectal cancer. Next, please. And this graph is showing incidence rates of colorectal cancer by sex, male and female, by race ethnicity. And this confirms what we've always known, which is that non-Hispanic Black men and women in California do have the highest rates of colorectal cancer. Next. With regards to incidence trends by stage, now we're just for simplicity, I'm showing you the trends for males and females combined. We are seeing large declines. I think this is a great success story, especially that we are seeing a decrease in the disparity, particularly for Black and other populations. So we definitely are seeing more equal rates in the latter years. And the other noteworthy trend to point out here is that we are observing a recent slight increase in colorectal cancer incidence rates for Asian American Pacific Islanders. Next. With regards to age, again, this is, you've all seen this in the news and in our data, this is well publicized, but again, focusing on the bottom two lines, we are seeing rapid increases in incidence of early onset colorectal cancer. So specifically those diagnosed in the 40 to 49 year age group, as well as the 20 to 39 age group. Next. And again, this is showing the incidence rates by county. The state average rate is 34.5, but we do see some counties, especially in more of the central parts of California, that have higher than state average rates that you can see here, the top 10. Next. And this is colorectal cancer screening from the BRFIS data. And interestingly, those counties that we're showing as having high incidence rates also have lower screening rates. So that definitely there's a correlation there. And so you could see here whereas the state average is 67.4, we have some counties in the central parts of California that have very low colorectal cancer screening rates in the 40s. Next. By payer status, again, we see this pattern that we saw with breast cancer, which is that those who are insured by Medicaid, public insurance, and non-insured have much higher proportions of colorectal cancers diagnosed in regional, but also distant stage disease. Next. And these are incidence trends by stage. So we see trends of localized stage and regional stage declining, but stable trends for distant stage disease. Next. And finally, mortality trends by race. Again, a great success story in terms of the rapidly declining trends in mortality among the Black population, but also declining trends observed across all other racial and ethnic groups. Next. And finally, let's look at cervical cancer. Next. The most noteworthy pattern that you can see here, which is very striking, is the increase in cervical cancer rates at 1.13% per year among Hispanic women. Next. And with regards to age, I think another striking pattern that you see at a glance here is the increase in cervical cancer incidence in the 40 to 49-year age group. Next. There's some variability by incidence rates as well. The state rate is 7.4, and you see some of the counties here. For example, Lake County is having a rate that's almost double the state rate. Next. And with regards to screening, there's actually not a lot of variability in screening across counties. These are the top 10 counties with the lowest screening rates, but they're very close to the state average. Next. And by stage, we see declining trends in localized disease, but increasing trends in regional disease. Next. By payer status, I think what's interesting here that's a little bit of a different pattern than the other two cancer sites is that we do see large proportions of cervical cancers diagnosed at regional and distant stage, also for the Medicare insured folks. Next. And finally, mortality trends by race ethnicity. We are seeing declining mortality trends across all of the racial and ethnic groups. Next, so I just want to do just a quick summary of the patterns that we saw because I know I flew through that really quickly. For breast cancer, we noted that incidence rates are increasing rapidly for Asian, Pacific Islander, and Hispanic women, as well as for women aged less than 50. With regards to stage, we saw distant stage incidence increasing in all racial and ethnic groups, especially for Asian and Hispanic women. We saw that the proportion of distant stage disease was highest, almost twofold among those on public insurance. Mortality rates still remain highest in Black women, but are declining for all racial and ethnic groups, except that they were stable for Asian women. Next. For colorectal cancer, we saw that incidence rates continue to be highest in Black males and females, are declining over time for Hispanics, declining over time in all groups except that they were stable in Hispanics and increasing in Asians. They're decreasing rapidly for age 65 and older, but increasing for early onset breast cancer. Localized stage incidence is decreasing such that the rates are now similar to regional stage disease, and distant stage was highest among those with public insurance. Mortality still remains the highest in Black persons, but they are also seeing the most rapid decrease and generally declining for all racial and ethnic groups. And next, finally, for cervical cancer, we are seeing the striking rapid increase for Hispanic women, but decreasing for other groups, and high and increasing rates for this 40 to 49-year age group. Incidence is increasing for regional stage disease, and we see that the distant stage disease proportion was highest among those with Medicare and other types of public insurance. Mortality is observed to be declining in all groups and most rapidly in Black women, such that the disparities are closing. And that's all that I had. Thank you so much. Sorry, it was a lot of data.
Yeah, no, thank you, Dr. Gomez. I know we asked you to cover a lot in a short amount of time. So thank you so much. And those summary slides at the end are golden as references for some of the trends we're seeing in California. So we don't go far. We're going to do questions in a moment, but we're going to continue with another very brief data presentation from Dr. Daniel, goes by Stoney Anderson from the California Colorectal Cancer Coalition. Again, the bio document was shared in the chat. And then we'll have Q&A for both of our data presenters. So as a reminder, please use the Q&A feature in Zoom. You can also use that Q&A feature if you're having any kind of connectivity issues or you have any other questions for us. Dr. Anderson, the floor is yours.
Okay, thank you, Raquel. And thank everyone for attending this because we are saving lives. So next slide, please. Over the next few minutes, I will outline the screening rates for breast, cervical, and colorectal cancer in 2023 and 2024. It's important this is not survey data, but publicly reported data from the Centers for Medicaid and Medicare Services, CMS, Health Resources and Service Administration, HRSA, and the California report card that's posted by the California Office of Patient Advocates. The references on this slides, and they will be shared with you with a recording of this webinar. Next slide. This is from the Office of Patient Advocates website. They only have 2023 data, and as you can see, we are average compared to the United States but well below the 90% average. Breast and cervical are doing much better than colorectal cancer in the 70s, while colorectal cancer screening is only 61%. And over the next few slides, I will compare these rates to our federally qualified health center screening rates and the Medi-Cal screening rates. Next slide. This shows the federally qualified health center data. It's part of their uniform data set. And as you can see, all three cancers are above the United States average, and except for the colorectal cancer screening rate, which is right at it really, in 2024. More importantly, these rates lag behind the commercial screening rates seen on the previous slide. The gap is about 10% lower for both breast and cervical, but it's a problematic 20% lower for colorectal cancer screening. Next slide. This slide shows the Medi-Cal screening rates compared to the national Medicaid screening rates. Colorectal cancer screening rate is given for two age ranges for some reason, the 45 to 49-year-olds and the 50 to 64-year-olds. As you can see, we are much better than average in all three cancers. Unfortunately, the gap between California's Medi-Cal performance and California's commercial performance is about 20% for all three cancers. Next slide. The next slides are the maps of the colorectal cancer screening. I'm in the California Colorectal Cancer Coalition, so I pull these maps. And it's reported for about 40 states. I love them because they show that California is in the second quartile and well above the national average on all maps. CMS is still reporting, as I mentioned, in two age groups, 45 to 49-year-old and 50 to 64-year-olds. And this slide is the 45 to 49-year-olds in 2023. And as you can see, we are dark, and that means we're saving more lives. Next slide. This is the 2024 data, and once again, we're still in the second quartile. We're still dark. And then this next slide, go ahead, next slide, this is the 2023 data for the 50 to 64-year-olds. And once again, we're in that second quartile. And then finally, the next slide, this is the 2024 data. And as you can see, we're increasing, but we're still in the second quartile. So, next slide. In summary, this data shows us improvement is possible in the Medi-Cal and the Federal Qualified Health Center's performance for screening for these cancers, because I'm sure we can catch up with the commercial screening rates. And the screening performance in Medi-Cal and California's Federally Qualified Health Centers will most likely rise together. As you know, about 72% of California's Federally Qualified Health Centers are insured by Medi-Cal. The uninsured rate is down to about 10%, but this makes sense for the late stage diagnosis that was presented earlier. We're screening at much lower rates in our Medi-Cal and in our federal qualified health centers than our commercial health plans. Finally, California is doing very well in screening our Medi-Cal population for these cancers. Thank you so much for all your efforts in creating these results, especially your health plan people that have called in. This is a challenge, but we will do better. Please let us know if we can help you. And the next slide is thank you, and contact me anytime. That's my email address and that's my cell phone number, and I'll be glad to help anytime we can, because the more we increase these rates, the more Californians we save. Thank you very much.
Thank you, Dr. Anderson. He means it about the cell phone too. We'll be talking at the end about some ideas that some of the collaborators have for supporting health plans ongoing. Let's take a few questions for Dr. Gomez and Dr. Anderson on their data presentations. First, there was one that you answered in the chat, Dr. Gomez, but I think it's worth everyone hearing. Why is the data as far back as 2022? Somebody asked.
Yeah, it really is quite an extraordinary effort for the cancer registries across California to collect cancer data for our diverse populations. We have thousands of hospitals, hundreds of thousands of, tens of thousands of reporting facilities, doctors' offices, radiation facilities, coroner's offices, hospitals, and we ask for a lot of data we meaning cancer registries. So for us to be fully confident that we have captured everybody in the state diagnosed with cancer for a given year, it does take that long. We are getting a little bit better. It used to take even longer. So right now, the most current data we have available for complete case ascertainment is 2022 diagnoses. We hope to have data for 2023 diagnoses in early 2026.
Thank you. Okay, let's see. From Arlene Silva, in terms of mortality rate, why are Asian populations stable and others have decreased? Is it because of late screening findings? And she's also asking about evidence-based practices to improve, but let's hold on that one since those are our upcoming presentations. But anything on the the question about Asian population mortality?
Yeah. Yeah, no, this is my favorite topic. So thank you for asking that question. It's in fact and I didn't plant the question. And in fact, it's an area that we're doing some very focused studies on. Many Asian ethnic groups tend to still continue to have the lowest breast cancer screening rates. And I think you definitely see that in this population having the highest incidence rates of late stage disease. So I think that definitely plays into the fact that we're not seeing a decline in mortality rates. In fact, I predict that over the next few years, we may actually start to see a creep up in the mortality trend among Asians. We also are seeing, as you saw too, a very rapid Asian Americans are experiencing the most rapid increase in incidence rates of breast cancer. And I didn't show you, but they also, in particular, they have the most rapid increase in early onset breast cancer. In California, we looked at some recent data. Breast cancer incidence rates for Asian Americans under age 50 are now as high as for non-Hispanic white women. So these are all patterns that are worthwhile to keep an eye on. And we don't know why. So that's why we're doing a lot of studies right now to try to understand why.
Okay, wow, there's a lot of questions, but I'm having trouble picking here. We are going to ask our presenters to answer some of these virtually, but let's see out loud. Someone is asking, I'm curious the reasoning for reporting breast cancer screening rates within the 50 plus population when USPSTF and ACS recommend screening starting at 40. So I believe this does have to do with the different, for a while it was 50 for USPSTF, but any comments on that?
Well, the screening rates I reported were the U.S. Preventive Services Task Force. That's what they used to generate that data. So,
okay, yeah. So for a time, it was beginning at 50 for USPSTF. So I think it had to do with the time frame of that data being reported. Let's see, kind of a general question. Do you feel that higher rates of screening are catching more cancer than that cancers that were previously missed, or do you feel the cancer rates are actually going up? So this is, maybe nuanced on each type of cancer that you touched on, but any points you want to hit on for that, Dr. Gomez?
Sorry, I'm trying to
Trying to
unpack the
find it.
question. Yeah. That is a really good question. I think that's a very nuanced question because there is this some cancer screenings are catching cancers at an earlier stage, so we should expect to see declines in the rates of late stage cancers, and that's why I showed some of the trends by stage. But some are actually picking, like colorectal cancer, are actually also capable of picking up cancers, precancers before they actually become cancer. So I think it's a little hard to directly correlate incidence trends without further information, such as stratification by stage, correlating them with screening rates per se. And as well, there's always this sort of latency period. In addition. But I think generally we do know that, I think looking at perhaps mortality trends could be a more meaningful indicator because then we kind of, aren't as confounded by this sort of lead time bias where we look at incidence rates.
The articles from 2018 on the California's Kaiser increase in screening rate showed that as they increased the screening rate, the incidence rate of colorectal cancer went up. But then it goes down and it continues to go down, and it went down over the study period, which was about 15 years, by about 20%, and the mortality dropped by about that amount. So when screening rapidly increases, as it did in the Kaiser during those periods from 2006 on, the incidence rates actually goes up. And that was also seen in the FLEX-SIG study done by Wendy Atkins in the United Kingdom and England. The incidence rates went up when they started, but then they went down over time.
Yeah. Okay, thank you so much, Dr. Anderson and Dr. Gomez, and thank you all for your great questions. I see some questions about early onset colorectal cancer and risk factors for breast cancer, so I think those will be great to hold on to for our subject matter expert presentations. So let's go on to our first subject matter expert presentation on colorectal cancer screening from Dr. Michael Potter. Dr. Potter is a professor of family and community medicine at UCSF, and so much of his research and his volunteer leadership has focused on colorectal cancer and colorectal cancer screening. He's a current member of the California Colorectal Cancer Coalition. So thank you for being here, Dr. Potter. The floor is yours.
Thank you very much. Next slide. It's nice to be here. And I'm just going to whip through a lot of information also, and but hopefully some of it will be familiar to you, and maybe there'll be some new things that you'll learn along the way. Next slide, please. So this has already been mentioned, I think, but just to frame it a little bit, like, why does colorectal cancer screening matter? It is the second leading cause of cancer death in men and women in the United States still. And screening prevents cancer by detecting and removing precancerous polyps, and also it prevents mortality by finding cancer at early stages when they can be removed. And there's a 90% 5-year survival rate when it is found early. So we have great potential here for prevention of mortality, morbidity and mortality through cancer screening, which we don't find with a lot of other medical interventions. So it should always be a high priority for every healthcare organization to assure high rates of screening. And despite this evidence, many eligible patients do remain unscreened, especially in non-insured and non-English speaking patients, including those served by FQHCs, as Stony mentioned. And you can see there's a big difference between the national rates for screening versus screening in FQHCs, where many of these non-English speaking and underinsured or Medicaid insured patients are seen. Next slide, please. So there are I just want to go over the screening guidelines and test options. I think colorectal cancer is becoming, it's great. We have many different options for screening, but it can be a little confusing for people. So I thought I'd go over it quickly. Because of the increased incidence we're seeing in earlier ages, all of the guideline organizations are recommending screening for average risk people at age 45. And also everyone recommends trying to find out more about family history, because those people should often be screened earlier. And continuing until age 75, but also even as late as till age 85, if they are older and healthy and have at least a 10-year or 5 to 10-year life expectancy, it still can be beneficial. So that's important as well, to continue to screen after 75 in cases where people are healthy and likely to still benefit. A key message is that I didn't ask, can you go back? A key message is that no single test is best, and we should be using shared decision-making. Not all health systems have the same resources, so you may not be able to offer every single test, but offering a menu of options seems to be important. And the other important point is that if you are offering screening tests other than colonoscopy, the non-invasive tests, you have to absolutely consider and assure that they can get colonoscopy after an abnormal test. And one of the problems with the data that we have is that health systems always get credit for screening if you did any test, but really you shouldn't get credit for screening if you screen with a non-invasive test and don't complete it with colonoscopy, because colonoscopy is always part of the screening process in someone with an abnormal non-invasive test. The non-invasive tests we have, one of the best and most evidence-based approaches is to use fecal immunochemical tests. There are certain ones that have more evidence behind them than others that have been studied in large trials. They're listed there. They are low cost, they are easy to use, and many patients prefer them. And there have been studies in FQHC populations showing that actually home stool testing is often preferred to colonoscopy as an easy way to do it at home, because they maybe don't have time to take time off from work or do the prep. But the challenge with that is in these populations, if you're offering FIT, is that you have to do it every year. And if there's an abnormal test, you do have to refer them to colonoscopy. So it requires a fair bit of clinic organization to do a FIT-based program effectively. There's a newer stool test that combines FIT with a multi-targeted with a stool DNA test. There are 3 versions out now. There's Cologuard, Cologuard Plus, and Colosense. They are all effective tests. They can be done at home, and they have a slightly higher sensitivity for cancer than FIT. They are more expensive, and they do have more false positives, meaning that you'll have more colonoscopies as a result. They're currently recommended to be done every 3 years if you do that. There's CT colonography, which is a CT, otherwise known as a virtual colonoscopy. That can be done every 5 years. I think the challenge with that test is it's also expensive. It requires a bowel prep. It requires radiation exposure. And then the positive result, you still have to get a colonoscopy. So then you have to do another bowel prep unless you have them somehow in tandem. So that one is not used that often. Just in certain situations where you might want to be doing screening at someone, like might want to do a colonoscopy, but only if, someone who might sometimes it's in slightly higher risk patients who may be having you may otherwise want to get a colonoscopy, and you want to get some reassurance without doing a test that's quite as invasive. Then what's coming up next are these blood tests, which are cell-free DNA. There's the one that's approved right now is called Guardant Shield. This is great, the idea of having a blood test where a simple blood test you can order instead of a procedure. And it may be great, especially for people who aren't willing to do other procedures. But the challenge here is that they are lower sensitivity versus all of the other tests. And they are not as good at detecting. They don't really detect polyps, and they don't do very well at detecting early stage disease compared to some of the other tests. If you do have a positive test, as with all of these, you still have to get a colonoscopy. But it is better than not doing any screening at all. And then finally, colonoscopy, which is a test that can be done every 10 years. It detects and removes polyps, and it is a comprehensive exam. It does require a prep and sedation, time off work, transportation issues come into play, and there is a small risk of complications such as bowel perforation and so forth that one has to be aware of. Next slide. As I've sort of alluded to, if you're going to be doing colorectal cancer screening, you really want to have a comprehensive approach. You should have a menu of options. I think emphasizing stool-based tests for at-home use and ensuring access to colonoscopy is important. And I think making sure that colonoscopy is available and the preferred option for high-risk or symptomatic patients. We obviously, if someone's coming in with symptoms of abdominal pain and bleeding, you don't necessarily want to do a stool test and ignore and write it off as nothing that needs to be investigated if the stool test happens to be normal, for example. So we do have to think through our menu of options and make sure that we're guiding the patient to the appropriate test option in certain cases. It requires a team to do colorectal cancer screening effectively. In a clinical setting, you need to engage the medical assistants, the nurses, and the front desk to help identify patients who might be due for screening and distribute FIT kits. I think we don't want to rely just on the physician who may have multiple competing demands to ask about screening. Of course, the clinicians should have systems to remind them to offer it as well. I think that it's important to have a level of enthusiasm about screening tests with messages to patients. I think, like, if you have a nurse that says, well, you could do the stool test, but it's kind of icky and most people don't want to do it, then people want to do it. But if they have a message like, this is an easy test, all our doctors recommend it, and it saves lives, people are much more likely to do it. And then there's many phases of patient navigation that need to happen in order to have screening. So there needs to be some you have to initiate and request screening. You have to generate demand for screening among patients. People have to be reminded to complete their non-invasive tests sometimes. After the test comes back, if it's abnormal, they have to be navigated to colonoscopy, and even after colonoscopy, the recommendations for when to rescreen or whether there's any additional treatment that people need to be navigated towards those things as well. I think one of the things that happens is in FQHC situations, we show you the big difference between screening in those populations versus in insured populations. And why do we think that is? Is it because FQHCs aren't working hard to do the best they can with these populations? It's absolutely not. Having worked in some of those settings in my career, I know that sometimes the people in federally qualified health centers are even more committed to the individual patients than you see in a private setting. But it is challenging because we have underinsured or uninsured patients. We have patients who are confronting homelessness. Language barriers are much more common, transportation barriers, time off work, and also often a very high comorbidity burden. So with this comprehensive approach, the additional layer of things that FQHCs have to do is to tailor them to the populations that they have. So if you have a lot of homeless patients, you need to think about, well, how are they going to do a colonoscopy prep? What are you going to do to support them? Or if they have language barriers, what are you going to do to make sure that all the materials are in a format that people can understand and follow? Next slide. Successful interventions, we've seen many successful interventions at FQHCs. It's interesting to see, some of the rates. We have an FQHC, a couple of FQHCs in San Francisco that have screening rates in excess of 70%. So we know it's possible. And those settings, they often will have patient education materials and video instructions in multiple languages available. They'll have instructions to complete FIT that have no words, that are visual and pictograms that make it easier. There are standing orders for medical assistants to offer or pen screening tests. They don't just rely on the physician to do it. They often will include outreach with mailed FIT. We know that works. And then in-reach, offering FIT outside of normal checkups. So like during chronic care visits or urgent care visits or visits to the nutritionist, or in the case of like the work that I've done is offering it at the time of your annual flu shots if they have clinics. If you have clinics where a lot of people over 50 are coming or over 45 are coming in, there's plenty of opportunities to say, oh, by the way, you also need this, and you give it to them. And then the system needs to support all this, so that there should be reminders in the electronic health record. If possible, it can reduce the burden of the work burden to have text reminders to remind people to follow up on appointments or follow up on returning kits. And then I think we found is really important for the abnormal fits is that every clinic should have a registry of people with abnormal tests that need follow-up and really assure that loop gets closed. That is one of the biggest problems. Probably up to 50% of people with an abnormal FIT test do not get a colonoscopy within a year. And when that happens, we know that those people have a much higher risk of having advanced colorectal cancer if and when it gets diagnosed. And again, a unified message that everyone can follow. So if you adopt any one of these things, that's going to help a little bit. But what really benefits is when you adopt many of these things. Multiple strategies lead to higher performance. Next slide, please. And I just want to highlight these are great resources for any clinic that wants to work on this problem. The Preventive Services Task Force has the guidelines. The CDC has the community guide with evidence-based interventions for multiple screening tests, but including for colorectal cancer. The National Cancer Institute has a website with evidence-based interventions that are research tested that you can look at. The National Colorectal Cancer Roundtable really is probably the single best place to go for practical advice and about how to structure a program. And of course, the American Cancer Society as well, which sponsors the National Colorectal Cancer Roundtable and also provides resources for patients, especially and wonderful, beautiful posters that you can put up in your waiting rooms and so forth. And then I'm just gonna, if you're interested in the FluFit program, which is the program that I've developed, a lot of these resources and links are there as well. Next slide. And then finally, I think, we think about what are the challenges. I think the challenges are competing demands and inertia, like we continue to do things the way we're used to doing them, and it's hard to start something new, and clinics are understaffed and workloads are increasing. At the same time, we have all these issues at the level of the federal government. We don't know whether the U.S. Preventive Services Task Force is going to continue in existence and whether we're going to be able to have the evidence to support coverage and so forth. Medicaid and other systems are being cut, which is going to be especially hard for federally qualified health centers. So in the face of all these challenges, we have to look for opportunities. I think when there can be pay for performance, these screening goes up. I think that one thing that will encourage clinics to work on colonoscopy completion is I think NCQA is likely to start recommending reporting of colonoscopy completion tests after abnormal non-invasive tests. I think people start to pay attention to things when it starts to be required that they report on it. I think that blood tests can help reach unwilling patients, but it's not a first choice. I think Cologuard and these stool DNA tests are an advantage for some clinics in that, if you get it done, it's covered by Medicaid or Medi-Cal. You only have to do it every 3 years, and they offer their own systems to try to support patients to complete the test, which can be helpful. I think there are going to be some new AI-supported tools for targeted outreach and navigation. And I just want to remind you about C4's Small Grants and Technical Assistance Program for any of you out there that are working in FQHC settings. We provide small grants for that, and we've seen those clinics that participate really increase their rates. Next slide. I think this is my final slide, and it's just to remind you for primary care teams, the way to really approach this is to have if you care about colon cancer screening, assign a champion, someone who's going to really track and push the team forward. Look at your workflows and define where they could be improved. Remember that every visit is an opportunity to discuss cancer screening, offer this menu of effective options, and track abnormal tests. I think these are straightforward things that clinics can work on. And then for health systems leaders, I think the clinics need your support. They need to be incentivized to achieve high performance, because one thing I have seen is that clinics do not focus on improving performance in areas where they're not incentivized because they have too many things to do. So many things to do. So if the health plans care about colorectal cancer screening rates, they need to incentivize the practices to achieve high performance. And I think not just like financial incentives, but other types of like providing technical assistance, providing sample education, patient education materials, things like that can really help, because why should each clinic have to invent it on their own? And health plans can really help with these types of things. And then if you have data that you can share with the clinic about their performance, that's really helpful. And so I think there are ways that health system leaders, whether it's within a consortium or at the level of a health plan, can really make a difference here. And I think that's really all I wanted to say. That's probably more than enough. Next slide. I think if you have questions, I'd be glad to try to answer some.
Thank you, Dr. Potter. Thank you so much for that great overview. We're actually going to do questions together with you and Dr. Temkin as a
Okay.
side-by-side panel after Dr. Temkin's presentation. So I will remind everybody to please enter your questions into the chat. We'll also do some answering in there because we're running a bit behind. But let's move on to our next subject matter expert presentation on breast and cervical cancer screening. We're so excited to have with us Dr. Sarah Temkin, who's the Senior Director of Early Detection at the American Cancer Society. Dr. Temkin is a gynecologic oncologist who's worked as a clinician and scientist in academic medicine for over 2 decades. Thank you so much, Dr. Temkin, for being here. Take it away.
Thank you for having me. And if you could go to the next slide, I just wanted to say, and the next slide, I just wanted to say one word about the American Cancer Society, which has been in existence for over 100 years, with the mission of creating awareness about cancer amongst the public. The vision today is to end cancer as we know it for everyone, and this is accomplished through advocacy work, support for research, and direct support to patients and their families. And the next slide. We are all here today because the burden of cancer in our society remains high. Amongst there are new cases, the incidence of new cases in the United States is close to 2 million people per year, and deaths are over 500,000. Amongst women, breast cancer remains the most commonly diagnosed cancer and the second leading cause of cancer death. And the next slide. Although overall, women are less likely than men to have a cancer diagnosis during their lifetime, women do have unique trends in incidence and mortality. Specifically looking at breast cancer, you can see that over the last several decades, we have seen an overall increase in breast cancer, which Dr. Gomez talked about very specifically in the state of California. Female breast cancer death rates, however, have been quite a success story, with over 40% reduction over the last several decades in deaths from breast cancer. Cervical cancer, meanwhile, has become a rare disease, but still is important, and the cancer that is most reasonably to be eliminated amongst disease sites. If you can go to the next slide. I just wanted to sort of emphasize something that Dr. Potter was just talking about screening as a process and a program, that the goal of screening is to improve cancer outcomes. And so that sort of happens in two buckets. The one that we're talking about today, screening occurs in asymptomatic individuals. However, there are patients who can benefit from early diagnosis because they present with symptoms and have a timely workup. I also just added incidental findings to this WHO graph because there are occurrences where patients do have an early diagnosis just because they happen to be in the right place at the right time and have something identified. And also that tumor biology influences all of these aspects in terms of who's symptomatic, who's not symptomatic, and whether cancer is diagnosed early or not. The next slide. So moving into specifics on breast cancer, I think everyone in this room or in this virtual room is pretty familiar with breast cancer screening guidelines. The American Cancer Society recommends that breast cancer screening begins by age 45 and occurs every other year in women over 55. The next slide. These guidelines do differ slightly from the U.S. Preventive Services Task Force, which recommends screening beginning at age 40 and has an exit age of 75. The next slide. Specific to cervical cancer, there are new guidelines that were published today, and I didn't update my slide deck because I wasn't sure how that was going to work. But the age of onset of beginning of cervical cancer screening is unchanged in today's guidelines. The American Cancer Society recommends starting screening at age 25, recommends primary HPV screening through age 65, and an exit after age 65 for patients who have had adequate screening up till they've reached, and negative screening up till they've reached age 65. The next slide. And again, these guidelines are different a little bit from other guidelines. Particularly, I just want to point out to the under 30 age group, where the American College of Obstetrics and Gynecology and the U.S. Preventive Services Task Force both recommend cytology for women under 30. As well as HPV testing or co-testing for the other age group. And the exit for screening is the same. If you could go to the next slide. And so overall, we heard a little bit about this too from Dr. Gomez, but rates of screening in the United States are I'll call them acceptable. They're not quite meeting goals, but they're also not terrible. This is true for both cervical cancer screening and breast cancer screening. Although I will just note here that for all age groups, for all races and ethnicities, cervical cancer screening has not recovered post-pandemic, unlike screening for other disease sites. And California screenings are pretty similar to US screenings overall. The next slide. There are pretty significant differences in geographic adherence to screening. And this is just specific to California, and Dr. Gomez did this in much more detail and much more nicely than I can. But this just is, I think, a reflection on how multifactorial access to screening is in terms of residents in a rural community, access to transportation, access to childcare, healthcare coverage, and many other factors. The next slide. Despite these pretty good overall screening rates in California and the United States, we still see a lot of late diagnoses in the United States, across the United States. In breast cancer, it's almost a third of patients diagnosed at late stage, and over half of cervical cancer diagnoses across the United States are at late stage. And again, this varies pretty remarkably based upon the state you live in, and even more granularly when you look at county level data, which is on the next slide for California. So we see both in breast cancer and cervical cancer some reasonably wide variations on where late stage diagnoses are. And these don't map on perfectly to access to screening and adherence to screening, although that is a factor. The next slide. So we are all here today to think about how to overcome some of these barriers to screening. And overcoming barriers to screening is one of the ways that I think we're all committed to improving cancer outcomes. But these all exist on various levels, including individual and community obstacles such as fear and mistrust, stigma, languages, and on the system and structural levels as well, for things like care coordination and cost of care. The next slide. And I also just wanted to emphasize that there are barriers across the entire screening process. It's not just getting the mammogram or the cervical cancer screen, but after the screening test is performed, the initial test is performed, patients also need to receive results, schedule follow-up, get time for follow-up testing, receive their results, and even today in the United States, a significant percentage of patients after their diagnosis for cancer are still having either delaying their cancer care or foregoing cancer care because of financial cost and burden. The next slide. And so the breast cancer screening process, I think, is one of the places where we do a reasonably good job across the system. The average time to biopsy after an abnormal mammogram in the States is about 14 days, but still a third of women don't receive follow-up after an abnormal mammogram, and these times are longer for younger patients and patients from underrepresented racial and ethnic populations. The next slide. The cervical cancer screening process, I think, is even is pretty tough for a lot of patients. We know that even today, with the process that we have, 3/4 of patients are up to date on their screening. About half of those receive a timely biopsy or evaluation for their abnormal screen. And the median time from biopsy to cancer treatment initiation is over 2 months. And these are all opportunities to improve cancer outcomes. The next slide. In cervical cancer, specifically, I'm just because this week is all things cervical cancer all week long, I just want to mention specifically that it's been 20 years since we've had a vaccine for cervical cancer, and 50 years, more than 50 years since we've really had widespread effective screening in the United States. And yet you can see from these incidence and mortality curves, it's been 20 years where we have not seen the declines that we should have been seeing across both cancer incidence and mortality. The next slide. And so today, as part of the new guidance on cervical cancer screening, the American Cancer Society endorsed self-collection. In May of 2024, there were self-collection kits approved by the FDA for use in clinical settings. And in May of this year, a home device was approved for HPV testing, which is currently available in 12 states, including California. The next slide. The efficacy and accuracy of these self-collection tests have been really pretty widely demonstrated as reasonably equivalent to a clinician-collected test. They're significantly more sensitive to detection of high-grade dysplasia than cytology, and have a comparable sensitivity and specificity to a clinician-collected specimen. The next slide. And so just, when people are thinking about this as they process the new guidelines, most patients who are eligible for primary HPV testing are eligible for self-collection. There are groups of patients who are not considered average risk for whom self-collection is not appropriate. Those include people with things like coexisting conditions like HIV, or people with a history of DES exposure. And I just would like to remind people that for patients under 30, because of the differences in guidelines, and those patients who have Medicare coverage, there may be differences in reimbursement for primary HPV testing. The next slide. And so the most exciting thing about self-collection to me is this extension of the settings in which cervical cancer collection can be performed. Half of cervical cancer patients have never been screened in the United States. And so we have the opportunity to greatly expand how we reach those people who are not being screened or who are being underscreened. Before self-collection, healthcare professionals needed to be trained to do a pelvic exam. The patient might have required a standalone appointment. Specialized equipment needed to be carried in the office. Lithotomy position, speculums, sterilization equipment, and with the availability of self-collection, really the ability to do a first screen for cervical cancer can be done in any healthcare setting where the patient can go to a private area, sort of similar to giving a urine specimen. The next slide. An emphasis on that this has really been very broadly shown to be acceptable to patients across multiple settings. The main benefits perceived by patients include the ease of performance, less embarrassment, no or less pain, and privacy. Whereas I think the harm that many people are concerned about is potential to miss a physical exam finding that would have been identified with a speculum exam. The next slide. Um, and so the the last thing I want to make note of about self-collection is that this pathway will change because there's not an ability with self-collected cervical cancer screening to do a reflex cytologic examination. There will be more abnormal findings on initial screen, which means that there may be more patients referred for clinician-collected specimens or colposcopy, which is going to change referral patterns within a system. However, I think this still can be relatively easy integrated to systems and has the potential to improve cancer outcomes. The last real slide that I have is around not forgetting about timely workup of patients who have symptoms. And so for breast cancer, those are things like pain, a lump, or a nipple discharge. Those patients need to be seen. And for cervical cancer, patients with abnormal bleeding, pain, or urinary symptoms, may be somebody who needs to be more thoroughly investigated. And then lastly, I have a handful of ACS resources that people might be interested in. We have a tool that is available for use called ACS Cancer Risk 360 that a patient can, in under 10 minutes, evaluate their own cancer risk and get personalized recommendations for screening and other factors. The next slide is our ECHO program. And if anyone is interested, we have several ongoing early detection ECHO programs right now. And the last slide is a self-collection webinar that's being held in January as part of the Cervical Cancer Roundtable program at the American Cancer Society. And then I hope I gave a lot of information really fast, and I'm open to any questions.
Thank you, Dr. Temkin. I think we were overly ambitious with our agenda because we have so much jam-packed, but it was wonderful to have your expert presentation as well as Dr. Potter's. We'd like to direct you to answer. There's some questions coming in the chat. If you could answer there, and then we'll take responsibility too for summarizing some of those main questions that would benefit the group and sending them out. But since we really, really want to hear from our two health plan presentations, we are going to move on to our health plan case studies. We're so happy to have with us two Medi-Cal Managed Care Plan representatives to hear about this work in practice. And so we're pleased to have with us Dr. R. Douglas Matthews, a colorectal surgeon and the Chico Regional Medical Director for Partnership Health Plan of California, and then April Wetzel, a quality improvement program manager at Gold Coast Health Plan, and she'll be sharing about Gold Coast's breast cancer screening effort. So we'll start with Dr. Matthews, we'll go to April, and then we will be able to do that panel Q&A. So Dr. Matthews, thank you so much for joining us today. The floor is yours.
Thank you, Raquel, and good afternoon. Next slide. So we're wanting to give an update on our efforts to shift the colorectal cancer screening curve, and this sort of incorporates many of the discussions that Dr. Anderson and Dr. Potter have brought up. Next slide. So as full disclosures, I'm still a practicing colorectal surgeon, although at this point my clinical practice is mostly endoscopy, both diagnostic and screening. I am a regional medical director for Partnership Health Plan for the last 2.5 years, which ironically is the period of time that Partnership has been putting a lot of focus into colorectal cancer screening. Just last month, the local hospital became a NAPRC certified rectal cancer center of excellence that we've been working on for probably 15 years of efforts. helping out in Tehama County north of us with a collaborative with UC Davis's Cancer Center working on colorectal cancer. And we're going to be having that same cancer collaboration here in Butte County starting in January. And I'm a little biased, but I'm hopeful that we can get colorectal cancer as the first cancer we lean into here as well. Next slide. So a brief overview, we'll talk about the cancer challenges that we're seeing here in Northern California, some current regional data, some pilots that have been implemented here in partnership, and some of the data that we're getting as our preliminary results, and then adding into what Dr. Temkin was just discussing, saying, can we link up cervical cancer screening in a similar way and move forward with some self-testing that will bear similar fruit for cervical cancer rates. Next slide. So this is the 24 county footprint of partnership as it goes. We've been asked by these 24 counties to provide the Medi-Cal coverage for them. And essentially north of I-80 in Northern California is partnership's footprint, unless you're in a county that has a Kaiser. If you have Medi-Cal, you have partnership. Next slide. And so here's that same map, but showing us those hotspots that were discussed earlier for colon cancer incidence. And for me in the Chico office, I have Butte, Glenn, Colusa, Yuba, and Sutter counties. And Sutter County is the only county there in orange. All the rest of my counties that I'm responsible for are in the highest group of colon cancer incidence in the state. Next slide. And this sort of maps over the top of that same map the availability of gastroenterologists to be specialists and to help. Obviously, this doesn't take into account the 3 colorectal cancer specialists as colorectal surgeons that Butte County has, and obviously the other general surgeons that some of our more rural counties have doing colonoscopy and screening. But it speaks clearly to the need to have a varied option for patients for screening because colonoscopy just isn't available in some of these areas. Next slide. And this is not as up to date as Dr. Anderson's numbers, but it does show that California continues to improve over time. In 2020, we were down at the bottom of the pack, and we are making strides towards fixing the issue. But for all of us on the national scene, we're hoping to get screening rates well above 75 and even into the 80% range, and we still have room to move up in California. Next slide. This had been mentioned in one of the chat questions. And what about the increasing prevalence in our younger population? So on the left side of those dot plots, you can see that in the younger populations, 20 to 24, 25 to 29, 30 to 34, we're seeing the largest increases in incidence. And we're doing much better in our more aged population, who we've been working on for many years. And so their incidence has been dropping as we've been screening them for many years. But the younger population is certainly proving to be at risk. And that's the reason for in 2018, we shifted the age from 50 down to 45 for initiating screening. Next slide. So as I mentioned, about the time that I came to partnership in 2023, they were having a partnership with Exact Sciences to see could we improve the rates of screening that we're seeing in our clinics. And so this was the pathway that they came up with, generating a gap list, which is a joint process between us at the health plan as well as the clinic. Then the clinic providers doing a quick chart scrub to make sure that we're screening the lower risk population instead of the high risk population. Cologuard then has a bulk order placed and letters go out to the patients co-branded, saying that the PCP feels it's important that they get colorectal cancer screened. The kit then arrives to the member's house, and there's some outreach that Exact Sciences has been helping us with to remind the patients and or answer any questions they have about providing the return. The kits are returned back to us through Exact Sciences, and then they send a list both to the providers and to us at the health plan of the positive results. And those are all prioritized so we can get them in. As mentioned, it doesn't do us much good to have positive results without those patients then going on to colonoscopy for either polyp removal, cancer diagnosis, or it was a false positive and will follow you in the future. Next slide. So here's the initial data from that pilot in 2023. We had probably 3 or 4 clinics that we started with, a total of 1,300 shipments of kits out. Kits returned was 281, and the positive results of those screenings were 29 individuals with positive Cologuard results that went on to be sent for colonoscopy. Next slide. And in a year after implementation, we went from 1,300 to almost 13,000 kits being sent. Again, 3,153 returned, still that 10% positivity rate for 293 individuals who otherwise wouldn't have been picked up in the system for a screening study. And at least clinically for me, I see about 50% of these individuals having either a cancer or an adenoma at colonoscopy. Unfortunately, there's still 50% of those folks who have a negative study, but it got them in the door and got the procedure performed. Next slide. And so this data is a little bit busy, but I've separated into regions, and you can see some of the results of how patients are participating and how the health system as a whole is doing. And so the counties are across the bottom, paired up in 3-year intervals. So you can see that over 3 years from 2022 before the pilot through 2023 with the pilot through 2024 when we're starting to adopt this across the network, the increases that are happening. And certainly some of these increases in our more populous counties like Shasta County are pretty substantial. In some of our more sparsely populated counties like Modoc County, it's a little bit more of a struggle. Of note, Shasta County has some FQHCs that had participated in the C4's pilot programs for screening. And so we expect that some of those results are also from that collaboration. Tehama County is a little bit interesting as an outlier where they haven't done a whole lot. And then you see a huge spike in 2024. And I'll discuss that a little later, but towards Dr. Potter's points, it really is the collaborative effort that gets things started. And so it hasn't been as much the offering of studies in the clinic setting there as much as the entire county making an effort towards colorectal cancer screening that made a big jump in their data. Next slide. And so in parallel, you can see that colonoscopy numbers also have increased in those areas. And that's one of the challenges that I have as I speak with my gastroenterology colleagues, that as we push for more stool-based studies, that they're concerned that their rates of colonoscopy will drop off. And this data is really helpful for me to say, no, you're going to have plenty of work to do. In fact, you may have even more work to do. And the goal that I've had is to shift the mindset from having more and more colonoscopies to having more and more appropriate colonoscopies in high-risk patients. And as the number of benign screening colonoscopies that were negative drop from doing the stool studies, we replace all those people in the work queue with patients who have high-risk positive Cologuard's FIT tests or symptoms. Next slide. So similarly, here's in the Northwest. Again, you can see Lake County, which is another one of our counties having trouble with their cancer incidence. increasing. Mendocino as well. Unfortunately, some of our Mendocino and Humboldt counties don't have as much access to endoscopy. Next slide. And again, this is the challenge that for Humboldt County, even though we've seen that exponential growth in their FIT tests and Cologuard tests, we're not seeing that same exponential growth for colonoscopy just because access is so challenging. Next slide. Some of the challenges that we're finding is that getting our larger populous counties down near the Bay Area to buy into this has been a little difficult, although Sonoma County is certainly an outlier and has increased their use of stool-based studies by 18 times over the course of 3 years, which is pretty incredible. That's tough because the scale is off compared to the other slides, but 2,000 studies in the year for Sonoma County. We're pretty proud of the progress they've made. Next slide. And similarly, here's all the colon cancer screening with colonoscopy that's paralleled those increases. And as you can see, they utilize this a lot more in those southern counties than the stool-based studies. Next slide. So in the eastern region where I've come, we only have data from 2024 when they joined the plan. The data for 2025 will be coming out soon. This is all claims data, so it's difficult for us to follow it without closing out the year. But again, the highlights are the areas that are more populous, we're doing more screenings. Some of our less populated counties are still struggling to keep up with the valley counties. Next slide. And again, some of the challenges that we see in parts of our region, the Yuba Sutter area, while we have some gastroenterologists, none of them are contracted with us to provide care in the Medicaid arena. And so many of those folks are also not being served quite as well. In Butte County, we have a lot of gastroenterologists, and so that's why our numbers continue to remain high. We all take Medi-Cal here. Next slide. So I mentioned just briefly that Tehama County numbers, we began a collaborative there with UC Davis, the county health department, the local hospitals, the surgical leaders, the surgeons are the ones who perform endoscopy in that region. But getting the health clinics there, bringing the payers in, and all of us leaning together into the screening really is what made the difference, going from 2 screening procedures a year to well over 100. So stay tuned for more progress in that arena. Next slide. And then just a quick mention that we've leaned into this area of self-swab, doing some pilots down with Dr. Colleen Townsend in our southern regions, and getting some of our larger FQHCs to offer the standard screening for cervical cancer. And if a patient declines, then offering them self-swab there in the office setting. The pilot took place before the May FDA clearance of the teal swab to be able to be done at home. And so at this point, we had been leaning into clinics doing the studies there. Those were sent in, and based on the positive results we were having from that pilot, we're expanding that into the home network. And now that the home swab test is available, we may be moving towards providing that to them in a similar kind of gap method, and then direct to consumer shipping of tests, and then follow up through their clinics. Next slide. And so thank you very much, and I'll give the time back to you, Raquel.
Thank you so much, Dr. Matthews. Okay, we're going to go to April at Gold Coast. And just a quick note, I hope most of you can stay with us just a little bit after 1:30 so we can get to questions. There's some great questions that have come in, and actually a few that were submitted ahead of time for both of our health plan speakers. So let's go to April from Gold Coast Health Plan. Hi, thank you so much. Thanks for being here. We can go ahead and skip to slide 5 since we're short on time. It'll be a table or a graph on our one more. There you go. Okay, so we are a county organized Medicaid health system in Ventura County, just north of Los Angeles. And we're going to talk about how we increased our breast cancer screening rate. And so we follow the HEDIS measure that I'm sure many of you are aware of. And so this slide here is showing our breast cancer screening rate looking as far back as 2018 to show you how we were performing pre-pandemic. The green 90th percentile high performance level is the 2024 90th performance level, so it's not exactly reflective of what those were in previous years. However, we can see that once the pandemic came, we dipped, and then we've been working our way up. But then in 2024, we exceeded the 90th percentile as well as exceeded our pre-pandemic breast cancer screening rate. And how we did that is what I will be talking about in these next slides. Next slide, please. So here's a list of the initiatives that I will be going over. Next slide, please. Okay, so in the end of 2022, we introduced a breast cancer screening member incentive, and initially this was a $40 gift card, and it reflected the HEDIS measure eligibility at the time, which was 50 to 74 years of age. And we have always offered our incentives to be what we call the in-house methodology, where members go get their screenings, send back their completed form, and then we mail them back their gift card. And that takes about 6 to 8 weeks. And so at the end of 2023, we introduced what we call point of care gift cards. And so looking at breast cancer specifically, we have 2 radiology centers that are affiliated with our hospital health systems. We have 3 large health systems that we are contracted with. And so we have provided them with the physical gift cards, which are Walmart, Amazon, and Target, and they provide the gift card to the member after they receive their screening at the radiology center. And so current day, our incentive is the expanded age range. We actually expanded the age range prior to the HEDIS measure, which expanded its age range to include 40 actually this year, but we did that last year in anticipation of that HEDIS measure changing. And then we increased the gift card amount to $50. And so in total, between our in-house methodology and our point of care methodology, we distributed just under 3,000 gift cards. Next slide, please. So another big initiative that we really capitalized on last year was partnering with Mobile Mammogram Van, Alinea to be exact. And we worked closely with our health system partners to get the van in various locations throughout the county. And we worked together to make sure that the van was in areas where there was low access and a high population of our patients. The vans require a quota of so many members needing to complete their screenings per day. And so the clinics, they were in charge of scheduling all of these appointments and making sure that members showed up. So they were doing lots of reminder phone calls and same day walk-ins if for any members who didn't show up or who canceled at the last minute, they were trying to fill those schedules. In addition, we provided them with the $50 gift cards and that they were passing out during the events, and we had a total of 18 mammogram events in 2024. Next slide, please. Another activity that we did was we had a quality improvement team member call our 13 other independent radiology centers, so ones that were not affiliated with our hospital systems, on a quarterly basis to determine when the next appointment availability would be. So then we could take those results, that information, and bring it back to our health system partners, who then would relay this information to their clinic staff to tell patients who are seeking mammogram appointments, where they will get an appointment quickly and where one might take a little longer. Next slide, please. And then lastly, in 2023, we launched our quality incentive pool and
program. It's a provider incentive program, and all three of our major health systems participate in this. The breast cancer screening measure is a part of the performance measures that they are incentivized and funded. And through that program, they would let us know different strategies that they were doing to increase their rates. And in addition to the things I already talked about, they were doing things like extending Saturday hours and after-hour appointments. And next slide. So this slide is looking at each of our major health systems, their performance of the BCS measure over a 3-year period. 2022 was their baseline rate before the QIPP program started. So you can see an increase in each of them throughout the years. Next slide, please. So just a high level kind of wrap up what we thought what made this successful was having a multi-pronged approach with robust interventions, strong clinic partnerships and alignment, and meaningful financial support for both providers and members. And that's it.
Thank you so much, April. What a great example of a well-rounded approach. So like I mentioned, we're going to go a couple minutes over our time, hoping most of you can stick on, but we are going to send questions to all. I would love to have Dr. Matthews pinned on here because the first question is for you, Dr. Matthews. Margaret has noted that the percent positive rate for your patients from the Cologuard test was about 10%. That's lower than what Exact Sciences generally quotes, which is encouraging, certainly, as far as the volume of colonoscopy needed. Do you have any thoughts on why this cohort might be a little lower? She says possibly a younger population represented or something else.
Yes, that's a very good point. We haven't stratified out the patient population to figure out why it's lower than the typically quoted numbers. My suspicion is that you're exactly right, that it's a healthier population, that the kits are going to potentially also the younger population that just has a lower incidence, even though their rate overall has been increasing. But the likelihood that any one of the younger patients is going to have a positive result is low. So yes, I think there's some sampling bias that's involved. Obviously, the tests aren't any different. How they're being run isn't any different. So it has to be that the population that we're testing is different.
Thank you. I did get a question submitted ahead of time about community health workers. If either, especially with the new community health worker benefit with CalAIM, if either Gold Coast Health Plan or Partnership Health Plan are integrating community health workers in your outreach for cancer screening. That's for either of you.
Quickly comment, we haven't directly been working with them from the health plan, but I know that many of our partners in the clinics sometimes will utilize their resources in that fashion.
Mm-hmm. Anything from you on that, April, about community health workers?
We do have community health workers. I believe that I'm not totally clear exactly the use of them. I'd have to get back to you guys on that.
Okay, no
Yeah.
problem. Well, there's another question about this was more for, I believe, referring more to mailed fit campaigns. So not so much the Cologuard, but I'm guessing you all might have input. What do you do when a health plan and a health system both distribute a colorectal cancer screening test and the results come out different for the patient? So like two fit tests with different results.
I can answer that.
Yeah, go
Yeah,
ahead.
sure, go
If
ahead.
anything's positive, you need to follow.
Yeah.
I
If
agree.
it's positive, they would do something about it. They
All
would
right.
get the
Thank you, Dr.
colonoscopy.
Potter. Yeah, so always going with the positive result, making sure to follow up on it. That point has been made.
The
All right, thank you. Let's see. I
Quick
don't
question,
see. Oh, go
quick
ahead.
question, Raquel, for April. April, your performance improvement program for your breast cancer screening is great, but now that colorectal cancer is going to be held to a minimum performance level in 2026, which is great news, will you set up a performance improvement program for colorectal cancer screening with Gold Coast?
We are actually already using Exact Sciences. I'm not directly involved in that project, but I know that it's also been successful for us thus far. I think it's only been a couple of months that we've been working with them directly. But as far as the quality incentive program, I believe that colorectal screening will be a part of the measures that will be in that funding pool.
Wonderful.
Mhm.
Thank
Dr.
you.
Matthews, do you have any, do you think having the minimum performance level for colorectal cancer screening, your approach is great. I applaud your work. Will you do anything different now that it's one of the measures you have to have a minimum performance level?
Yes, we've been anticipating that it's going to be a requirement from DHCS. And so even this last year, we've had it as part of our quality incentive program, and clinics are incentivized to bring their rates up. Yes.
Thank you.
Thank you all. And that's actually a great segue. We can transition away from this panel. Just a couple closing comments. Wanted to mention that some of the organizations that brought you the content today have just really want to continue supporting health plans in your work, and specifically like having the California Colorectal Cancer Coalition as one of those organizations, specifically for colorectal cancer, given that it will be an accountable measure now. One of the ideas on the table is to convene a health plan learning collaborative to provide a space for health plan team members to learn from each other or learn from national experts specifically on colorectal cancer screening as you all are doing this work. So in our evaluation, which is being dropped in the chat right now, you'll see some general questions about today's content. Please, everybody, fill that out. But then for our health plan team members, if you could indicate your interest in an opportunity like that, that would be great. Another thing being dropped in the chat is two resource documents. These are really useful references of ACS, like most popular cancer screening resources from ACS, many of which are from our national roundtables, which have been mentioned. So they're developed in collaboration with a lot of other leading organizations. There's two documents. One is resources for members/patients by cancer type. And then the other one is cancer screening resources for healthcare professionals, which includes, all of you on today, as well as, your provider networks. So with that, I want to say some thank yous, and thank you also for those of you that hung on with us a little bit of extra time today. Thank you to our amazing speakers. Thank you to the organizations that collaborated to bring you today's content. And then thank you to each of you for joining and for the work that you do every day to help our community members benefit from life-saving cancer screening. So we wish you a wonderful rest of the day and week. Thank you.
Thank you all for attending. This is great. Thank you.
Bye-bye.
Bye-bye.
Have a great day.